take just a moment to do this. Okay.
Okay, thanks for joining us today. This is Scott Safford. I'll be leading off the presentation today. What we're hoping to accomplish today is I will be providing some background information on why we think covering chronic pain in a primary care setting in a comprehensive manner is important. We will also be talking about the program that we developed here in Central Oregon. We'll be talking about some of our data that we've collected, and then we'll finish up with some future directions that we're hoping to go in as we continue to develop this program. Just a quick point, this is a modified version of the presentation that we gave at the CFHA conference last October, for those of you who may have been at that. We'll try to scatter some cartoons through the presentation to keep you awake out there. So first of all, we want to look at why is it important to address chronic pain in a primary care setting, and why do we want to do it in an integrated manner? A major component of this is that chronic pain is a very prevalent problem. Data from the American Academy of Pain Medicine indicates that about a third of the population, so 100 million individuals, have chronic pain in the United States. And this is approaching twice the number of diabetic, cancer, and cardiovascular disease. And considered hot potatoes by physicians who oftentimes will want to refer them out because they're difficult to have easy access to tertiary pain clinics for a variety of reasons. Part of that is insurance may not cover it. Part of it is many patients live in rural settings where they may not have easy access to a clinic in their region. Other places, there's long wait lists to get into the tertiary pain management clinic, so it's just not a feasible option for many folks. However, despite this difficulty accessing services, primary care physicians oftentimes have some concerns about treating chronic pain patients because they can be difficult to work with. So some of the concerns that have been voiced to us by the primary care physicians we've worked with is that there is an increased burden of care with chronic pain patients. They tend to be very time-consuming patients. There's a high rate of comorbidity, and that includes both medical comorbidity as well as mental health comorbidity, high rates of depression, substance abuse, diabetes, obesity. So a lot of very chronic health conditions that are frequently comorbid with chronic pain. There's also concerns among many physicians about addiction or diversion of opiates, so they have concerns about prescribing medications that may be problematic for this population. Another concern that often comes up is that it's not always clear what the etiology is of the underlying pain condition. A lot of chronic pain conditions, if you do MRI, CTs, X-rays, scans like that, sometimes they don't show anything, but the patient is still reporting a high level of pain. There's also indications from research that sometimes when they do MRIs, you could see, for example, with low back pain or back injuries, you could see bulging discs or compressed discs and things like that. But comparing side to side, there are patients who have similar levels of functional impairment or physical impairment in their body but do not exhibit. So it's not really clear why patients have chronic pain and some people don't when they level of physical impairment physiologically. The other concern that we oftentimes hear is that the physicians oftentimes aren't comfortable with prescribing opiates. It's not always clear, what's an appropriate dose, how much is too much, how much is too little. And so it's just a difficult population to work with for many primary care physicians, and they oftentimes want assistance with helping with these patients. So as I mentioned, one of the concerns that physicians have is regarding substance use, abuse, misuse, dependence, or diversion. And one of the things that has been found in the literature is that physicians aren't all that good at predicting who might be abusing their shown that they're less than 50-50, less than chance when they try to predict subjectively who may be misusing. So that's why it is important to have a more objective screen for abuse issues, and Dr. Swanson will talk about that a little bit later. The other thing that we've seen happen in our country is that there was a period of time in the 80s and 90s where there was an emphasis on increasing opiate use. There was a belief that chronic pain or pain in general was being undertreated, and so there was a big push to increase the treatment of chronic pain, increase opiate use. And the downside of that is that the abuse of prescription opiates rose 71% between 1997 and 2002. So there's been kind of a pendulum swing more recently that physicians are now trying to crack down on opiate use and trying to reduce the utilization or reliance on opiates as the primary or only strategy for managing chronic pain. And so one of the things that we've also seen is that, at least in the state of Oregon, opiate drug prescriptions is the #1 cause of overdose deaths here in this state. Besides this, it's also important to keep in mind that not everybody who uses opiate pain medications is going to have addiction or misuse problems. So some research indicates that the prevalence rates of opiate dependence among chronic pain patients in primary care settings tends to be about 20 to 40%, depending on the study you look at. And this is a nice little graph that was created by Pasek and put together by Dr. Swanson that really illustrates that not everyone seeking opiate pain medications has a chronic pain condition, and not everyone receiving opiates for pain medication is an addict. So there's quite a range of opiate users and chronic pain patients, from chronic pain patients who are completely adherent to their treatment regimen and never have a problem. There's chronic pain patients who tend to be reliant on chemical treatments, what we call a chemical coper, so they're really looking for a pill that's going to make them feel better, and sometimes these patients are the ones that we have a hard time engaging in behavioral health as a component of their care. Then at the far end of the spectrum, there are folks who may abuse, but again, abuse isn't the same as addiction, so that's a separate category as well. And that's just among the pain patients who may be on opiates. As I mentioned, there's also patients who may or may not actually have chronic pain but are seeking opiates for various other reasons, recreational use, abuse, addiction. Another common problem that we see that co-occurs with chronic pain is depression. So one of the things that we see, and this is a bidirectional relationship, is that about 65% of depressed patients will also complain of pain issues, aches and pains, muscle fatigue, weakness, and things like that. So it's very common in depressed patients to have pain of some sort. On the reverse side, about 3/4 of chronic pain patients will also report depressive symptoms. So there does appear to be a bidirectional comorbid relationship there. And what we know is that many patients with chronic pain who have underlying or comorbid depression, the depression goes undiagnosed or untreated in primary care settings. It's just the physicians oftentimes are focused on the physical complaints or diagnoses, and they may or may not adequately assess and treat the underlying depression that may also be present. And the problem with this is that chronic pain patients who also have depression, they report more intense pain. So on pain scales, their pain levels tend to be higher. They report less control of their lives. They report more unhealthy coping strategies, which is common among depressed patients. And they simply report less quality of life. So they just have a harder time. So we see have chronic or have comorbid mental health conditions like substance use or depression, anxiety, things like that. In a traditional medical setting, they will oftentimes refer them out to specialty care, so specialty mental health services. But what we know is that only about 20% of individuals with mental health issues actually seek out or receive treatment from mental health professionals, whether that be psychologists, social workers, counselors, psychiatrists. The vast majority of individuals with mental health concerns are seen in primary care and treated in primary care. Primary care physicians are the #1 prescribers of psychotropic medications. And what we see also is that when physicians do refer patients out for specialty mental health services, only about 30 to 50% of them will follow up with that referral and actually engage in services. The other concern that we see, particularly with chronic pain patients, is that when they have comorbid mental health issues or behavioral health concerns that may be exacerbating their chronic pain, a physician may say, well, we'd like you to see mental health to work on the behavioral components of your chronic pain. And for many chronic pain patients, there's some stigma associated with this. They have either been told or have developed on their own the impression that others believe that their chronic pain is all in their head. And so sometimes when they're referred to mental health or behavioral health to address the behavioral health components of their chronic pain, they react to that as feeling like that the doctor's not taking them seriously or thinking that it's not real. So we have to make sure that we pay attention to that. So as we can see, I think there's a number of reasons why it's important to address chronic pain in a comprehensive manner in a primary care setting. So what we work to do is create a step care model of addressing chronic pain within our primary care settings where we work. And it was important to us to develop a program that was evidence-based, and we wanted something, we didn't want to have to reinvent the wheel. So this wasn't something that we created from scratch. We pulled from various sources. Both Dr. Swanson and I have worked in chronic pain settings and have delivered chronic pain services, so we didn't want to start from scratch. So one of the things that we did is we pulled from the VA has a comprehensive step care program. And so what we focus on in primary care is what is listed as step 1 on this particular slide. So developing a pain school program, assessment and referral program, screening for comorbid diagnoses, and when necessary, we try to treat as much as we can within the primary care setting in collaboration with the physicians, but when necessary, we do try to help get patients access to specialty care, whether that's chronic pain, tertiary care clinics, or secondary mental health services or substance abuse services if those seem relevant. And really what our goal is in developing this program is threefold. So we want to increase patient access to skilled interdisciplinary treatment. As we know from the research, a biopsychosocial model really is the most demonstrated effective way to manage chronic pain. And so we want to make sure that all patients, not just the ones who have access to a tertiary care clinic, we want to make sure all patients have access to interdisciplinary treatment that's evidence-based and appropriate. We also, part of our goal here is improving cost effectiveness of treatment of patients in our primary care setting. And as you may be aware, specialty care clinics oftentimes are much more expensive than receiving care in a primary care setting. So we're trying to reduce costs as well. And then the third component of what we're trying to accomplish is a big part of our role here is trying to improve the physicians' care of the patients. We want to help them feel more competent in the work they're providing. We want them to feel more satisfied with the care they're providing to their patients.
All right, so this is Dr. Swanson, so he's turning it over to me, and I'm going to kind of go through a lot of the nuts and bolts of what this looks like in our practice. And then I'm also going to talk about some of the outcomes that we've been measuring since we implemented this in 2012. And part of this starts with detection and prevention. Since that statistic of 20 to 40% of patients tend to can have abuse or addiction issues, it's really important that we are detecting those that are having problematic issues with chronic opioid therapy, and also engage in prevention for those that are at risk for developing problematic issues with chronic opioid therapy. So before we implemented this, there was really sporadic use of a controlled substance agreement or a contract. And since we implemented this, there's more systematic and regular use of a controlled substance agreement and contract. And part of that contract also includes alternative therapies that are commonly used for the treatment of chronic pain. We also implemented random urine drug screens. As Dr. Safford mentioned earlier, a physician's hunch is actually less than chance on who they guess who is having problems with their opioid therapy or other substances of abuse. And so to date, the random drug screen is the gold standard for that detection. And I think it was in June of 2012, the state of Oregon rolled out the Oregon Drug Monitoring Program, which is, we call it the PDMP within the state. And this is a really great tool for our physicians as well as ancillary providers who also have access to this tool to see how patients are utilizing the system to access other controlled substances. So it is a statewide program that you can access. The other part of this is setting up community-wide controlled substance policy standards. I sit on a provider panel for our coordinated care organization. For those of you that want to know about what that is later on, I'll be happy to say that, but in the interest of time, I'll stay on topic. Research indicates that really implementing a morphine equivalent dose cap is in the best interest of safety of the patient. And there has been new research that indicates even less than 120 milligram morphine equivalent dose daily cap is actually safer, but within our region, the Medicaid payer source has implemented on their own a 120 morphine equivalent dose daily cap, and we implemented that within our clinic in 2012. We also implemented a standard to avoid the polypharmacy of controlled substances. When Dr. Safford referred to we are #1 in the nation for the death rate for chronic opioid therapy, it's usually in the instances where there's polypharmacy of controlled substances, and that polypharmacy is usually a combination of opioids and benzodiazepines. Because chronic pain patients have such high level of comorbidities, there is a tool for risk stratification and systematic screening for those particular conditions. And that becomes very important. Sorry for the audio connection. It just said that we were lost. So I hope I'm going to pick up where I think it left off. So we use commonly wide tools to detect comorbid conditions. For example, we use the PHQ-9 to detect depression, the General Anxiety Disorder 7 to detect anxiety. We use the Pain Disability Index. And then the opioid risk tool is actually a tool to help us risk stratify people who may be at risk for problems with chronic opioid therapy so that we can give our physicians better advice how to do risk mitigation with opioid therapy and alternative strategies for pain management. We implemented Pain School, and Pain School is really a chronic disease management course, and I'll talk more in detail about that later. And then between the primary care physician and our behavioral health consultants, also based on risk stratification, we determine who's appropriate for secondary and tertiary care. And we do coordinated care referrals to those particular agencies to increase the likelihood that people will indeed adhere with that treatment and transfer outside of the primary care setting. So Pain School, we designed it with we worked in collaboration with our Medicaid payer source, which so that in a fee-for-service environment, so that we can kind of fit with what will be reimbursed, but also serve the most important needs of the patients as far as learning skills for chronic disease management. So it is a 4-session psychosocial intervention. And these classes are really packed. Each class includes providing information about chronic pain, working on applied skills to help manage chronic pain, and teaching various relaxation strategies. And we took a wide variety of evidence-based practices to include cognitive behavioral therapies, mindfulness therapies, and some of the acceptance and commitment therapies. And our topic areas include education on acute versus chronic pain, theories on why people develop chronic pain, using a pain diary, a pain scale, pacing, exercising and stretching, balancing productive activities, enjoyable activities and rest, problem solving, goal setting, and maintenance. We talk a lot about maladaptive thinking patterns with specific focus on catastrophic thinking about patients' pain, because that is one of the leading factors for functional disability for people with chronic pain. We talk about interpersonal relationships, sleep, and relaxation strategies. So you can see each class has a breadth of information for us to cover. And this particular course is mandated for patients in our clinics that are receiving chronic opioid therapy, and our physicians will not refill opioid therapies for patients that will not comply with this part of their treatment. It is really important, if you're thinking of doing something like this, to involve payer sources if you're in a fee-for-service arena. Most of the coverage is negotiated by contracts by our contracting department and the insurance carriers. And we had to work very closely with our payer sources in order for us to have our payer sources cover the cost of this service for our patients. Now I'm going to dive into some of the outcomes that we've collected over the past two years. We used the pain, assessing pain severity used a numeric rating scale. For functioning, we've used the Pain Disability Index. For psychological, we use the PHQ-9 for depression, the GAD-7 for anxiety, and risk stratification, the ORT. We have more systematic data outcomes on the PHQ-9 than we do on the other measures, because we're kind of early in the process on some of those other measures. And we also look at physician compliance, and we do this in collaboration with one of our payer sources, which is Pacific Source Community Solutions. So we look at documentation to best practices, adherence to random urine toxicology screening, the tracking of aberrant drug-related behavior, use of the PDMP, or the Oregon Prescription Drug Monitoring Program, and we do look at the adherence to daily morphine dosage equivalent caps and physician satisfaction. This is the demographics. We currently have 168 completers, a mean age of 53. You can see this is skewed to a more female, with 120 females to 54 males. And you really can see that there's kind of a smattering of payer sources, but the preponderance of payer sources that we have are usually within the Medicaid and the Medicare populations. Our PHQ-9 data over that 4-session class, I would have to say, is pretty underwhelming. We really don't even see a clinical range jump. So for those of you that are not familiar with the PHQ-9, a mean score of 8.94 is in a mild range of depression, and so is also a 7.83. So you don't see a clinical range jump. But we do feel satisfied with such a difficult population that we see any movement within this particular metric at all. And both Dr. Safford and I agree that this is probably not the entirely best metric to use. And so in future directions, we are definitely looking at different metrics. At this point, most of the outcomes we have on physician satisfaction is anecdotal. And what they have consistently advised us is that they they feel very, very good about having a program standard of care. And they also tell us that they feel less anxious about treating our pain patients and that they have more support. And they feel less anxiety having those difficult conversations surrounding opioid therapy on either problematic opioid therapy or why or why not chronic opioid therapy is indicated for that particular patient. Physician adherence, we're looking at 14 particular physicians. We have about 85% adherence to consistent use of a controlled substance agreement and 85% adherence to random urine drug screening, 85% adherence to the PDMP, and then 64% adherence to that risk stratification piece. Dr. Safford is just starting to roll that out in his particular clinic, so we expect many of those numbers to increase. And we don't have consistent ways to measure documentation to best practices, so that is definitely in a future directions for us. And in working with our Medicaid payer source, I had them pull about a 6-month period of claims data. And claims data can be quite controversial as far as whether that's a good metric or not. But what it is nice for us to see is we are able to see this broad brush of how patients are utilizing the system before and after anyone has participated in our integrated chronic pain program. So what this data range is that it gives us 6 months prior to initiation into this particular protocol and then 6 months after. And the N is quite small, but you'll see just in this small number of population in that date range, we were able to save specific to the Medicaid population $31,263.19. And Dr. Safford and I, on our own, elected to follow one particular case. And this particular person was a very high utilizer of the system. There was a question, it says, over what time period is the class spread? That's an excellent question, and so they're expected to come once a week for 4 weeks. So roughly a month period of time is how those are spread.
And if somebody misses a class, because obviously life happens and people may have to miss a particular class, we just have them plug into the next available class for the one that they missed.
But there is an expectation that within roughly a 2 to 3 month period that they will have completed all 4 classes as part of their controlled substance agreement to fulfill the requirement that they have. And if they don't fulfill that requirement, then the physician can say they have not complied with their treatment agreement and not refill a chronic opioid. So we followed this particular case, and we followed her for over the course of 3 years. And to be fair, we included the cost of what my costs were because she was such a high-risk patient. I did follow her individually for a period of time. And you can see the ED utilization, and most of the ED utilization really was surrounding obtaining opioids or other controlled substances. And you can see utilization nicely has trended downward over the years since we had such intensive intervention with her, including pain school. And on this one patient alone, the savings to date is $19,498 just as a result of the intervention that we deployed. So when we started this particular intervention, we didn't have so many players on our primary. So we added other people like our nurse care coordinators and community health workers. And we have yet to kind of build them into the algorithm, but many of these are very high-risk patients that are high utilizers of the system. And so what we would like to do is to have more systematic ways of how they're interfacing with these patients in the team. We definitely want to continue to have healthcare utilization as one of our primary metrics. pharmacy data is very, very important. ER use and specialty care use. And so far, our Medicaid partner is very good about working with us on claims data, but in private insurances are not so easy to get claims data from. We're looking at different ways to more systematically measure physician satisfaction versus just the anecdotal evidence that we have. And we're also looking at different ways to measure physician adherence to the treatment model. And we finished early, so and that's in large part because I'm a fast talker. So I'm going to open the floor for questions at this point, and go from there.
Okay, this is Polly again. We do have a couple of questions, and it looks like we may have had a couple of individuals raise their hands. So let me get started with that. Again, for the audience, if you do have a question you'd like to type in, there's a little question bar at the bottom of your navigation bar, and I can field those for you. Or if you would like to ask a question verbally, you can raise your hand and I will unmute. You, and you can do that. So the first question we have, Dr. Swanson, refers to a slide you had earlier in the presentation, and in that slide you talked a bit about the proportion of primary care referrals for chronic pain patients that are followed through with. So the question is, what do studies say about the proportion of primary care referrals for chronic pain patients that are followed through with? Please confirm that your slide was referring to primary care pain referrals to behavioral health consultant follow-through for all patients.
Oh, so I think you're referring to the slide that I did towards the beginning about referrals to mental health services, and that wasn't unique to chronic pain patients. That's based on research on patients in general. So it was a more general patients in primary care that are referred out to specialty mental health services like a mental health clinic that 30 to 50% actually follow through with that. So it wasn't specific to chronic pain, and I don't have specific data on follow through rates with chronic pain patients in particular.
Okay. A second question, at what point are the screening measures administered to patients, and how often are they repeated?
So the initial screening is usually done when patients establish care in our clinic at this point. So we do a fairly comprehensive screening that includes a variety of measures. So the PHQ-9, the GAD-7 I already talked about. We also look for PTSD, substance use, the opioid risk tool, pain disability index. So the insomnia severity index or questionnaire, I think it is. So we do that when they establish care in the clinic, and that's meant to provide specific guidance to the physician about the risk for chronic opioid therapy. And the opioid risk tool nicely gives you a risk stratification within mild to moderate to severe, and then suggestions for risk mitigation to the physician on how to manage chronic opioid therapy or if it's contraindicated. And also, so we do that once. Now, if we detect somebody has depression or anxiety or substance use issues, then we will do that on every clinic follow-up until the patient achieves symptom remission in that particular category. And so that is done on a repeated measure, and the frequency of that repeated measure is usually dictated by how frequent we're choosing to see the patient. We also do screening within pain school, and that's every time they attend pain school.
Yeah, so each class, we give them the PHQ at the beginning of the class. At the first class, we give them the pain disability index, and the fourth class, we give them the pain disability index. It was one of the things we were trying to see if we were Because the PHQ and depression isn't the focus of the class, we've been trying to identify a measure that might more adequately capture changes that we're creating in the patients that we're seeing. So we added the Pain Disability Index that we do at first class and last class, but we haven't had an opportunity to crunch that data yet.
Very good, thank you. I am going to actually open this up to the audience. Brian Keefe has raised his hand. So Brian, I'm going to unmute you now if you want to ask your question. Brian? Okay, I can't hear Brian at this point. We may be having some technical difficulties. Let me try another. Jessica Cassidy. Let's see, Jessica. I've unmuted you, but it looks like your computer is self-muted. If you'd like to ask a question verbally, you can unmute yourself and do that. Okay, seems like we're having some difficulty with that. I do have some additional questions that have been typed in, and Brian and Jessica, if you guys want to type in your question if our audio is failing for some reason, I'd be happy to field these. The next question we have is, if you decided not to use the PHQ-9 over time, is there another tool you would recommend that is a reflection of quality of life versus symptom measurement?
Well, there's several of those that you could use instead. The McGill Pain Questionnaire has some quality of life metrics that are embedded within that particular one. And the SF-36, symptom, what is that one?
Symptom checklist.
Right. There's one we can't remember off the top of our head.
Well, and sorry, one of the things that we run into is in a primary care setting, we're trying to use measures that are brief. Because we want physicians to also use some of these measures, and they're not going to want to use ones that are extensive. So we want ones that are brief, and we want ones that are freely available. So a lot of the measures that are out there you have to pay to use, or they're a little complex in using it or scoring them. And so we want something that we can administer quickly, doesn't take much time, and doesn't take much time to score. So there's a trade-off between data collection and ease of use that in a functioning clinic, fee-for-service clinic, we don't have as much luxuries as we might in a training setting where we could do more comprehensive testing.
But other ones are, and forgive me if I screw up these names because for whatever reason I'm drawing a blank, but I think it's the SF-36. I think you have to have permission to use that one. I think it's free to use that one, but you do have to access permission to use that one. And then the other measure that I think would be helpful is why I can't think of the whole name is the Duke.
It's called the Duke, isn't it?
Quality of life. Forgive me. I'm sorry for if anybody created that test and I'm offending you. I'm sorry, but I can't remember the name of it. But those are other measures that you could easily implement over time, and that would probably capture a little bit more of that the symptoms and quality of life issues that you're asking about.
Very good. Another question, once the 4 sessions of Pain School are completed, is there any further contact regarding classes or psychoeducation?
You know, it's been so far on a case-by-case basis, and I would have to say that's probably one of the things that we've debated for 2 years. Usually it's identified as the patient returns for follow-up with the physician on any particular issue. And so at this point, no, not really systematically. There's been ongoing debate among the physicians on whether Pain School should be offered as a requirement once a year. which is not necessarily a bad idea, but one of the problems we have is commitment from our payer sources to pay for that again. At least within the Medicaid population, it is. Private payers aren't so difficult. And so that's one of the things I would have to say that we could definitely improve upon and look at a little bit more systematically is what happens after in that follow-up period as far as patients needing more care or benefiting from.
Yeah, and so the stock statement that I give to the patients at the end of the class is that you need to follow up with their physician and follow up with behavioral health as needed. So it's not systematic. And we would like to have develop booster sessions or something like that so we can more systematically maintain the gains. Because one of the things I've seen kind of anecdotally is following the class, patients do quite well for a period of time, and then over 6 months to a year or longer, we see some sliding back into some of their pain behaviors. And so we would like to develop a more systematic way of addressing that. But as Dr. Swanson mentioned, we had to work pretty closely with our Medicaid payer source in particular to get coverage for the pain class at all. Initially, they weren't willing to cover it, and so we had to do a presentation to them to justify and validate doing the pain class. And so they would only give us a certain number of H&B, health and behavior units, to cover, and so that they gave us enough to cover the initial intake and then the 4 classes.
Very good. Thank you, guys. We did have a couple of comments about the Duke Health Questionnaire or Duke Health Profile.
Yeah, thank you. Thank you for saying the name.
Thank you, guys.
Yes, thank you.
So we will, there's actually a link to the SAMHSA.gov site that we'll send out to all of the attendees on the list today, and thank you, Brian Keefe, for forwarding that on, but we will get that sent out.
Thank you, Brian.
And another question we have, is the Pain School curriculum available for other interested clinics to use? And or is that something you guys have considered?
Oh, absolutely. Dr. Safford and I are relentless do-gooders in the world, and we will give it to you for free. We did that after the last every presentation. For people that want it, we'll give it to you for free. Holly, if you want to collect email addresses and forward them to us, we'll be happy just to send it.
And we could probably send you more information than you could ask for. We send a lot of files on because our goal is we want this comprehensive care available to as many patients as possible. We ask that when we do send it on to people that if they expand on it or have other ideas to make it better, that they feed it back to us so that we could help improve our program as well. And we just ask that if people are going to use our materials that they at least cite that it's coming from us. But other than that, it's not proprietary. We're more than willing to share what we've created.
Very good. Thank you all. And to that end, we have had a couple of people ask about whether your email addresses could be made available to the group. So for the audience, please know that we're getting lots and lots of questions in, and we will forward all of your questions to the speaker. So if we don't get to your question today, we'll be able to they can contact you directly with answers. I'm going to attempt, we still have a little bit of time left, and I'm feeling like I'd like to try again to unmute one of the folks that has raised their hand. Kimberly Schuler, I've unmuted you. Do you have a verbal question you'd like to ask?
I'm sorry, no. I was just trying to get on the list for the email for the curriculum. Thank
Perfect. Thanks. We will definitely do it, and thank you for being brave enough to talk. Thanks. Okay. Another question we have. Can you comment on use of the DIRE score in a practice setting? Are you all familiar with that? Capital D-I-R-E. This question
I'm not sure what that means.
Is from Shelley Millsap. Shelley, if you have some additional information on what that is that you'd like to send, maybe we can forward that on. And
that was the D-I-R-E?
Yes, yes.
Okay. Yeah,
Not familiar with that.
I'm not familiar with that. I'd like to know more.
And additionally, why would a CPT code for a group, example 90853, along with an initial eval 90791, be sufficient to bill Medicaid?
Well, we're not billing those codes. We're billing under the health and behavior codes. So the initial eval under an H&B code is a 90, and then the group is 3. And that's where whatever the chronic pain condition is the primary reason.
And you can't use chronic pain as the diagnosis, because that's a mental health, a 300 level code. So
for an H&B code.
Yeah, so that's considered below the line by Medicaid
in our state.
In our system. So there has to be the specific medical pain diagnoses for us to bill the H&B codes.
One other question, guys. In your Pain School course material or curriculum, is it a part of the Stanford-based chronic disease pain management program?
It's not. We did not develop it based on that. Although I'm sure there's probably some overlap and components off of the Stanford. Dr. Safford had specialty training in chronic pain, and I did a 2-year fellowship in chronic pain. So a lot of that was really derived from our clinical experience and education, and informed by research that I had conducted over a period of time. So
yeah, so we pulled it from our existing information that we had, and also doing web searches and finding freely available sources to put the materials together. And with some of the pain classes, for example, that I've run, they were anywhere from 6 to 12-week classes, usually 1.5 to 2 hours long. So it was a chore for us to take as much information as we had acquired or accumulated in our head and boil it down to 4 one-hour classes. But we tried to hit the main points as best we could within the time that we could get allotted from Medicaid.
Very good. And just in the last couple of minutes, we've had a couple of people who've provided a bit more information about the DIRE tool, and it looks like it's a predictive model for narcotic compliance, published in 2006 Journal of Pain, questionnaire to predict if a patient will have issues maintaining appropriate use of narcotics.
Yeah.
And we will, we also have a link. Thank you again, Brian Keefe, for forwarding these resources that we will send out to all of the participants on the call today.
Thank you.
Yeah, and the opioid risk tool is a little bit similar, but that one I would be interested in learning more about.
Very good. Well, I want to thank our speakers today. It was a fantastic webinar, and I think just indicated by the number of questions and our audience participation, certainly something that folks are interested in learning more about, and we're so appreciative of your time. As I said, we'll be sending out these resources to all of the participants on the call today, and be sure to, I believe our webinar next month is on the primary care behavioral health model of integrated practice in a primary care setting, and that will be October 8th. Please feel free to go to the CFHA website under Learning Opportunities for more information. And finally, we're looking forward to our 16th annual conference, October 16th through 18th in Washington, D.C. We hope to see everyone there. Looks like we're going to have record attendance this year and have a great program in store. So we're very much looking forward to that. Again, thank you to our speakers today, Dr. Safford and Dr. Swanson, and we wish you all well. Thanks very much.
Thanks for having us.
Thank you for having us.